Welcome to our third conference, which is quite an achievement. This piece of work really began after the first conference when the Lancet requested us to try and write a piece of work that would bring together the evidence on extreme exclusion. And since that time, you know, the wheels of research turn fast. And so here we are on the third conference 3 years later with some data for you. This is a collective effort. There's an enormous amount of heavy lifting being done by our colleague Rob Aldridge, who unfortunately can't be here today, with some great insights and support from international leaders in the field, Stephen Huang and Marette Nordentoft. So this is very much a collective effort. I'm going to set the scene and just give you a little bit of a background to the work and why we're here, why we're doing it. Andrew is going to do the serious data bit and provide you with the insights, the resolution, and then I'm going to come back on and just talk briefly in terms of what we can interpret from this, and most importantly, the questions that are unanswered. So, why are we here today? We're here today at our Inclusion Health event, and this is the definition that we've used. Inclusion Health is an agenda. It's an agenda about trying to address extreme inequality, and we've tried to weave this definition to capture the multiple dimensions to it, the dimensions of poverty, of marginalisation. The dimensions of multiple health problems that compound one another, interact, and perhaps most importantly, that dimension which is the failure of mainstream services to actually recognise and meet the needs of the people that we're talking about. Data, not too exciting in the wrong hands. Why do we need data? Well, quite simply, the populations that we work with, the people that we work with, they are largely invisible. And unfortunately, invisible equates to ignored in too many cases. Ignored equates to basically not being on the map in terms of not only not getting some service provision, but in many instances getting no service provision because the populations themselves are not commanding resource within the eyes of the system. Why do we need data? Well, we fundamentally have very little insight into trying to understand the health impact, the long-term health impact of many of the things we do. And similarly, we need much better data to inform the need for a different kind of service response. And what I mean there is early intervention. And this is going to be the enduring theme of this talk, because fundamentally this talk is about quite a staggering health inequality. So, the aim of the work was basically, it's not a traditional systematic review in that sense, it's an evidence synthesis to bring together morbidity data, data on people's illnesses and the mortality data, what they die of, from these 4 population groups who we know are very often intersecting and overlapping, but in many cases are the exemplars of deep exclusion. I'm talking about people who've experienced homelessness, people who've experienced addiction, drug dependence, sex working, and imprisonment. This is one of many examples that we could have chosen to actually highlight how these risk factors intersect, but it's quite clear from these data, which are in fact taken from London, quite contemporary data, over 1,000 people who were in a large study that we undertook looking at comorbidity. But as you can see, if we were screening in drug and alcohol service, it was highly likely that people who were using that service had also experienced homelessness and imprisonment. And similarly, if we screen in a hostel or a prison, the populations are totally intersecting, which raises some challenges from a methodological perspective if we're going to actually try and unravel this data to really understand the sort of cause or consequence issues. But we were really fortunate to have Susan Fitzpatrick presenting at our first conference, and a paper that she published in 2012 really shone a bright light on the fact that there's an incredible similarity in terms of the sequencing at which these adverse life events occur. Substance misuse, mental health problems tend to occur quite early, whereas issues in terms of rough sleeping, more extreme forms of visible exclusion, as it were, typically occur quite late in life. But nevertheless, there's a very strong causal pathway here, and it's quite clear that some of the adverse life events that occur later in life are, in fact, consequences of those that occurred further on. This briefly summarizes Susan's heroic work to basically look at these sort of forces of multiple exclusion, extreme exclusion in early, mid and late onset, as it were. Another huge challenge for us in trying to synthesize this data, trying to understand the evidence, is the fact that the definitions themselves are hugely broad. All the groups that we're referring to are poorly defined, particularly when we take this evidence synthesis out of the UK and look at it on a more international scale. But quite simply, and what we need to sort of stress, is the fact that all these issues are states. They are not traits. They are temporary. And again, that brings a dimension of complexity in terms of trying to understand how the duration of the event, the duration of the exposure, its frequency, its severity, and its timing, perhaps, in terms of the age of onset being most critical, how that impacts on the ultimate outcomes. As I've said, in terms of measurement, in terms of actually trying to quantify burden of disease, this raises specific challenges, not least because the populations are often invisible within general disease registers, etc. But also the denominators themselves present specific challenges. So, some methodological insight. Let's just imagine that in terms of homelessness, for instance. We know that homelessness can be transitional, people can bounce in and out. We also know that for many people, homelessness is episodic, and we know from many studies that have been undertaken that the deeper you go, the more likely you are to bounce back in again and ultimately end up being defined as, appallingly defined as chronically homeless. So the methods, quite simply, is a massive review of published evidence derived from the usual sources, Cochrane Review, Medline, Embase, etc. A lot of the heavy lifting had been done, in many cases, in terms of the fact that people had formally done systematic reviews and meta-analysis on specific risk factors around homelessness, etc. And so we didn't pull all the old papers. We basically relied on building on existing systematic reviews and meta-analysis wherever possible. As you'll see from Andrew's results, there's very sparse data on many of the populations that we're looking at, and therefore we resorted to other evidence sources in terms of large cohort reviews, cross-sectional studies, etc. Rob Aldrich did a lot of the heavy lifting in terms of the big data extraction, and the actual data itself was classified using the traditional international classification of disease coding. This in itself raises issues in terms of the fact that the data that we'll be presenting is pretty condition-specific, because it's very rarely reported as being one or more things. It's unfortunately it's identified as, or usually reported in the literature as one specific condition. And so we're really trying to extract meaningful measures of burden, i.e. prevalence, incidence, any standardized rate measures. So all five of us pretty much pulled this together and mapped all these papers into the primary ICD-10 coding categories. That's the intro. I'll hand over to Andrew for the main results. I'll be back.
Thank you, Alistair. Actually, just before I start, I'd like to take the opportunity to embarrass my colleague Alistair and just to let you know, I don't think it's widely known, but Alistair was recently awarded fellowship at the Faculty of Public Health by distinction. So this is a very rare honour awarded to very few people in the country, and it's really in recognition of his great work, particularly in homeless health. So congratulations to Alistair on that. On to somewhat more depressing issues. This is really showing the countries from which we had available data. We were trying to look at this as a problem in high-income countries, and as you can see, I think we've got a good spread of data from across those countries. This next slide is really showing we talked about the international classification of disease, and essentially that is a way of classifying pretty much every disease known to man into a series of chapters, thematic chapters, which are listed down on the left-hand side. And this graph really represents the extent of evidence for the different population groups that we were studying here. Homeless on the left, sex workers, drug users, and prisoners on the right. If you look at the color coding, essentially if there's no block, it means we found no studies about these particular causes of disease in these groups. And then the color coding from red is just a few studies through to the blue color, where we've got solid systematic reviews. And I think broadly what this shows is that the level of evidence for both homeless and prisoners is generally good, less so for drug users, and really, really very scant evidence on the health of sex workers. A lot of the studies, though, we were interested in studies particularly that would compare the health of these groups to the general population. Actually, a lot of these dots don't do that, and it's particularly in the homeless that we have this evidence of comparative morbidity and mortality, and so that's a lot of what the presentation will be focusing on. So I'm going to show you a series of graphs that will describe the excess burden of mortality for different causes in these population groups. And just to take you through that so that you can be clear what's going on, if you look at the axis along the bottom, which is labeled relative mortality, essentially anything that is above 1 means that homeless men have an increased risk of death from that condition. So for example, if it goes up to 2, then the risk of death is twice that of the general population. And so that's what the blue bars are representing. The dotted lines are really a measure of how certain we are, based on the size of the study, etc., about that estimate. And for each of these bars represents a different study showing from around the world. So if we start at the bottom, we can see we're looking at all-cause mortality due to cancer. And we see we get varying estimates, but consistently raised level of risk of cancer, somewhere between 1.5 and 2-fold increased risk. And then particularly, and perhaps not surprisingly, lung cancer featuring very heavily there, I think indicating the need for much more attention on smoking cessation. And then this is essentially the same pattern for women. Again, we're seeing this 1.5 to 2-fold increase in risk of the same cancers, including lung cancers, but also the cancers that are specific to women, like breast cancer, and like ovarian and uterine cancer. Moving on to, this is looking at infectious diseases, and we're showing both men in blue and women in red at the top for this. And so the thing to focus on here is the axis. So the previous axis for cancers, we were showing the relative risks of about 2-fold. For infectious diseases, we're talking more about 10 or 15-fold increases in risks of death amongst homeless populations for all causes of infectious diseases, and particularly for diseases such as HIV, although that may be very geographically dependent. Again, another area where there's really extreme excess mortality is deaths related to mental and behavioral conditions. And again, you'll see this axis is more in the 10 to 20 or higher fold in terms of increased mortality, and particularly those deaths related to use of psychoactive substances. Cardiovascular disease, again, if you look at the scale on this, we're moving back down in terms of the extent of the excess risk. So again, the scales, we're looking at somewhere around 1.5 to 2-fold for most of these conditions. But don't forget, that cardiovascular disease is one of the most common causes of death in the general population. So even these relatively, I say small, but comparatively small compared to the other conditions, increases in relative risk mean a very substantial additional number of deaths. And again, I think this really points to the need for more preventative work in this area. Certainly the general population increasingly getting intensive efforts to manage cardiovascular disease risk, and we need to be doing the same within homeless populations. And the same pattern for women. Moving on to respiratory diseases, again, we're seeing a substantial increase in risk, somewhere around 2 to 4-fold, particularly for smoking-related diseases. So, for example, chronic obstructive pulmonary disease, which is a very debilitating and lifelong condition, but also for the more acute forms of respiratory problems like influenza and pneumonia. And I think, again, that points to potential preventative measures, for example, vaccination, and trying to ensure that homeless people have the same access to vaccination. Gastrointestinal disease, again, we have higher relative risks here, and these are largely dominated by liver disease. And so this would be liver disease due to either viral infection, hepatitis B, hepatitis C, or due to alcohol-related liver disease. This graph is really looking at what are classified as external causes of mortality. And again, we can see this shocking increase in risk in terms of 10 to 20-folds increase in risks in things like poisoning, which, for example, would include drug overdoses, suicide, homicide, accidents. So huge burden here, both in men and women. We found less evidence for the health of prisoners, but we did find a very recent study from Scotland which looked at the relative mortality for people in Scottish prisons across the ICD chapters. And I think, again, we can see consistently across all of these areas of disease shockingly increased risk of somewhere between 2 and 4-fold compared to the general population. But here's another interesting and tragic slide. When one compares this with female prisoners compared to the health of the general female population, these relative risks are even further magnified, 10 to 20-fold increases in mortality. And then finally, a slightly different graph, and you won't be able to read all of this, but essentially what this is now looking at is rather than condition-specific mortality, it's focusing on all-cause mortality and the range of studies that have looked at all-cause mortality across these different risk groups. And again, consistently, we're seeing the varying estimates of how much that increased mortality is raised, but consistently high. And some of the ones that I've highlighted in blue really highlight most of this is homeless data, but there's also good evidence on increased mortality for sex workers, prisoners, and drug users. Thank you.
Numbers, but this is lives. This is lives, and the magnitude of risk is eye-watering here. It's as Andrew said, it's a tragedy. What else is pretty tragic is the fact that we're just presenting mortality data here, and the reason why we're concentrating on the mortality data is because that's the main body of published literature. There's very little comparative morbidity data. It's almost non-existent across these groups, which is an interesting finding in itself. And consequently, we're looking at end of life, reporting end of life. This is undermining our abilities to unravel causality. But it's clear from the data that the forces of exclusion, the adverse life events, addiction, homelessness, imprisonment, sex working, This impacts across almost all disease conditions, and some much more than others. In terms of this temporal sequence of events, it's clear that some conditions, particularly mental health problems, they predispose people to exposure to risk factors such as homelessness. But in most instances, the morbidities are caused by their inconsequence to exposure to a risk such as addiction and homelessness, and they're exacerbated by that exposure. We've looked at this sort of idea of trying to get more granularity in the data, try and understand how the severity and duration of exposure actually impacts on your health outcomes and opportunities. But I use this very simple sort of example of, again, using homelessness from different extremes, as it were, from, say, being a sofa surfer to right away being a rough sleeper. We don't really understand what shape the curve is. It's probably more like this. The longer you're in, the more devastating the health consequences. And so this is really raising some of the big questions. How do we stop you getting in the first place? The data doesn't really talk about multiple problems. As I said, the limitations of ICD-10 reporting in the literature is one condition, but we know from other data sources that exclusion is defined by multiple morbidities, multiple problems. The system is not very good at dealing with multiple problems. Similarly, we know that it's defined by multiple risks. Having an episode of homelessness hugely exposes you to risks of substance misuse and contact with the criminal justice system. We don't have hardly any data to inform our understanding of how people are actually using services and whether these health consequences are the result of poor engagement with services, etc. And finally, I come on to this as the most important bit. We really don't have the evidence base for early intervention, which is gutting. And unfortunately, we live in a system which is rather dogmatic. I don't want to start randomizing people into homelessness and crack addiction and imprisonment. We need better evidence to make people visible. And we're going to aim to do that. Probably the best option here is data linkage, big data linkage studies, to actually try and consent people to actually match their data into the existing national systems around hospital episode statistics, mortality data, etc. And then with that match, that enables you to not only look forward prospectively in terms of what an eventual outcome might be, but perhaps most importantly, it enables you to look back at some of the issues that have perhaps predisposed someone to be in that unfortunate position in the first place. Why do we need this data? Well, it's health equity. Quite fundamentally, some of the policy reforms we've seen in recent years have had a profound impact on people's lives and opportunities. We know that there's a significant rate in rough sleeping, for instance, and we know that the actual event of rough sleeping is going to have catastrophic health consequences. People should, politicians, decision makers should be made aware of the need to be sensitive to the laws of unintended consequences, and in some instances not so unintended consequences. So what else don't we have here? Well, we certainly don't have a sensible economic argument to actually back up the need for early intervention care. We are almost utterly devoid of sensible economic arguments to actually cost the price of failure. But it's quite clear from studies that have been published that people are currently using the health system in perhaps inappropriate points. For instance, emergency departments, it's not meeting their long-term needs, it's not having a long-term impact on their survival outcomes, and it's certainly not improving their quality of life. So to conclude, extreme exclusion, as by these exemplars using homelessness, using addiction, using imprisonment, using sex working, is catastrophic. It has catastrophic health impact in terms of your long-term survival outcomes. It's a huge source of frustration to us and colleagues in this room that we really lack that narrative, that evidence base to actually inform the need for a more proactive approach to prevention. To illustrate the argument, we're here in the UK, where there's political focus on addressing homelessness, but unfortunately that political focus is about removing the most extreme and visible form of homelessness, i.e. rough sleepers, from the streets. It's not about preventing homelessness, it's a debate around rough sleeping rather than house building. Similarly, within the prison construct, as it were, Britain's secret penal system, as we heard from Lynn, prison seems to be quite a convenient source of accommodation. The addiction issues, we're still bouncing between this lifelong chronic relapsing condition or a criminal justice agenda, similarly for sex working. Where's the consistent policy? Where's the narrative to inform prevention rather than punitive reaction? So the call, and we give this to you, I mean, how can we use these data? How can we raise this incredible health inequality? The magnitude of the effect, as we've seen, is eye-watering. How can we use these data to hold people to account? And thank you very much.
Welcome to